Hello dear friends, welcome to my channel. Today we are talking about radial nerve palsy. It's a condition caused by injury to the radial nerve, which runs from the upper arm down to the hand. The radial nerve controls muscles that extend the wrist and fingers, so damage can lead to weakness or paralysis. That we can call it wrist drop. Wrist drop is a condition where the wrist and fingers cannot extend upwards. The cases is trauma or fracture, compression, repetitive use or overuse of the hand, activities that involve repetitive motion of the arm and wrist can lead to inflammation and nerve compression. Some medical conditions like diabetes, certain inflammatory disease. The symptoms may be the patient might have wrist drop, inability to extend the wrist and fingers, or weakness, difficulty gripping objects or performing tasks requiring hand extension, numbness or tingling in the back of the hand, forearm, or wrist area, loss of sensation, usually on the dorsal or backside of the forearm and hand. Diagnosis: we can do the physical examination to check the wrist and finger extension and test the sensation along the radial nerve distribution. Nerve conduction studies and electromyogram. We can do this test to assess the function of the radial nerve and pinpoint the area and extent of damage. X-ray or MRI. We can do this test to rule out the fracture or structural issues. Treatment. First, we can do the conservative management for radial nerve palsy. In conservative management, we can do cock-up splinting or bracing that supports the wrist in an extended position to prevent deformity and enable function. Physical therapy, exercise to maintain muscle strength, improve range of motion, and aid recovery. Some medication, like non-steroid anti-inflammatory drugs to manage the pain. Occupational therapy to assist with adapting activities to improve hand functions. If the conservative management didn't work, then we can start the surgical innervation. In surgical innervation, we can do nerve repair or grafting. In cases where there is significant nerve damage or no recovery after several months, or tendon transfer. In severe cases, surgery may involve moving tendons to restore wrist and finger extension. Proximal humerus fracture. It refers to a break near the top or proximal part of the humerus, the bone in the upper arm. This type of fracture is common in older adults, often resulting from a fall or direct trauma to the shoulder. In younger people, it usually results from high energy trauma such as a car accident or a sport injury. The anatomy and classification. The proximal humerus consists of four main parts that can fracture the humeral head: the greater tuberosity, lesser tuberosity, the humeral shaft. The Near classification system is widely used to classify these fractures based on the number of parts involved in the amount of displacement. One part fracture. In one part fracture, bone pieces remain aligned with minimal displacement. In two-part fracture, one bone fragment is displaced. In three-part or four-part fracture, involve multiple displaced fragments and are often more complex. The cases: it can happen due to falls in older adults, low energy falls, especially in those with osteoporosis, In the most common cases is the fall. The trauma in younger individuals, high energy trauma such as car accident or sport injury, often caused by the fractures. The symptoms: patient might have severe pain in the shoulder, especially with movement, swelling and bruising around the shoulder and upper arm, deformity. In severe fractures, the shoulder may appear deformed, limited range of motion, difficulty moving the arm due to pain and muscle weakness. In diagnose, we can do physical examination to assess the arm and shoulder mobility, pain, and possible nerve or blood vessels injury. Also, we can do the X-ray. Initial imaging to confirm the fracture and assess alignment. CT scan provide a more detailed view of complex fracture to aid in surgical plan. The treatment: we can do conservative management. It's suitable for stable, non-displaced fractures. Immobilization: it's a process that a sling or shoulder immobilizer is used to keep the arm in place while the wound heals. Physical therapy begins after initial healing to restore range of motion, strength, and function. If the conservative management didn't work, then we can start the surgical treatment. In surgical treatment, we can do open reduction and internal fixation. In this process, metal plates, screws, or rods are used to hold the bone in place. Shoulder hemiarthroplasty or total shoulder replacement for severe fracture where the humeral head is damaged. Reverse shoulder arthroplasty. An option is elderly patient with complex fractures where traditional repair is unlikely to restore function. Occurs when the humeral head, the ball of the upper arm bone, is forced out of the glenoid cavity, the shoulder socket. The shoulder is particularly vulnerable to dislocation because it's the most mobile joint in the body, allowing a wide range of motion but sacrificing stability. Shoulder dislocations can be anterior, posterior, or inferior. It depends on the direction in which the humeral head is displaced. As we discussed before, we have three types of shoulder dislocation: anterior, posterior, and inferior. The anterior dislocation, it can happen when the humeral head moves forward out of the socket, often caused by falling on an outstretched hand or a blow to the shoulder, and it's the most common case in shoulder dislocation. The posterior dislocation, it can happen due to seizure, electric shock, or a direct impact to the front of the shoulder, and it's the least common cause in shoulder dislocation. The inferior dislocation is the rare case and usually result from hyperabduction where the arm is forced upward excessively. The cases, it can happen due to trauma or impact, repetitive strain due to overhead activity, loose ligament, or weakness. Some people naturally have looser ligaments, making their joints more prone to dislocation. In the symptoms, the patient might have severe shoulder pain, sudden and intense pain at the time of dislocation, deformity. The shoulder may appear visibly out of place with a bulge in the front or back, limited range or motion, difficulty or inability to move the arm. Numbness and tingling can extend down the arm or into the hand due to the nerve compression. In diagnosis, We can do physical examination. And physical examination, we can assess shoulder shape, location, and range of the motion. Some imaging, like X ray, to confirm the type and severity of dislocation and reveal fractures. MRI and CT scan to check for soft tissues, injuries, or labral tears. In treatment, we can do reduction. Reduction means repositioning the humeral head back into the socket. It usually down under the sedation. Immobilization. Immobilization, it's a procedure that a sling may be used for a few weeks to limit movement and allow healing. Some physical therapy. After immobilization, exercise help restore range of motion, strength, and stability to prevent future dislocations. If it didn't work, the conservative management, then we can start the surgery. In surgery, we can recurrent dislocation or severe ligament tears. Surgical intervention may be necessary to repair or tighten the ligament and joint capsules.